Okay, so let's get started here. Probably have some more people coming on. Appreciate everybody coming in, taking a look at dry needling for plantar fasciitis. I've got more content here than we can ever cover in a single hour, but I want to cover as much of this information as possible. And fasciitis through my trademarked Haynes method of neuromuscular dry needling offered through the Haynes PT Institute. Question of why do I do the webinars? With COVID and everything that's going on around that, with people hesitant to get out and go to in-person courses, I've been in about 8 months worth of development to move all of this content to a virtual situation, where my original certification course was a 3-course program. This online piece I've converted to an 11-course. The first course, the introductory course, is already online. It can be purchased and go through all of that content. And then the subsequent 10 deal with the other spine and extremity regional locations, as well as one on pelvic floor. So I hope to have the rest of that completed and available online by the end of the year, earlier if possible. But like I frequently say, I'm not just teaching these courses, but a full-time clinician as well. So as time permits, I hope to get the rest of that done. So during this program, if you have questions, feel free to hit the Q&A, hit the chat. Moderator will yell at me and let me know if there's anything pertinent that I need to cover. So that being said, let's just dive right in. Just some very introductory information, brief history on dry needling. And I talk fast. I cover a lot of content. I will have this recorded and it'll be on our YouTube channel later today or tomorrow. So if anything that's going too fast, you'll certainly have access to it again. Dry needling, brief history, that's been used by urine PTs, physios for decades. And over there, frequently referred to as acupuncture. Dry needling, this concept really started through the work of Janet Travell and her trigger point theory. Obviously, traditional Chinese acupuncture has been around thousands of years. And I'm going to talk about Texas here. The first formal training course in the U.S. was in '97, and the Texas Association proved its first dry needling course in 2008. And we didn't actually get a definitive AG opinion until 2016, affirming that dry needling within the scope of practice of physical therapists. A lot of states still struggle with that opinion and the scope of practice concern. Obviously, dry needling getting more renowned, getting more notoriety out there. I could say with my use of dry needling, it is my go-to piece for decreasing pain, inflammation in tissues. And so, but we've got a long way to go on getting the research that we need to support and back dry needling up. How does dry needling work? Lots of research, lots of theories, lots of ideas on how it works. Just kind of from a study, several studies listed here. But again, research is ongoing on physiology. And the general concept is that it'll increase blood flow in the area. It'll decrease taut muscle banding and the tenderness or the sensitivity associated with them. And it can decrease the spontaneous electrical activity of the SA or the twitch response. Although some research suggests that may not even be relevant for successful outcomes in dry needling. I can tell you myself, I'm not a trigger point guy. That's not what I'm looking for. I get excited when we do get that twitch response, but that's not what my focus is on effective dry needling and for outcomes. And then there are also some CNS and biochemical changes that could occur, suggesting that there are some local changes, but there are also more distal and proximal changes as well. Some general contraindications, relative and precautions. Number one, non-consent from the patient. Any of the things that we do, invasive or more extreme, the first trimester of pregnancy is usually a good thing to stay away from. Uncontrolled anticoagulant usage, any local infection. If we're in the occipital, suboccipital region, a patient with a Chiari malformation, you would want to stay away from that general area. If there are any implants, whether it's electronic implant or even breast implant, things of that nature, want to be very cautious of what's going on there. Pacemaker, talking to the, and this particular one was St. Jude. pacemaker manufacturer. They couldn't say yes or no. It would be problem to needle around or on or provide electrical current across. But until such research is presented that actually gives us that information, my general approach is in that area, I'm going to stay away from, especially the electrical component. In dry needling onto the structure itself, we should stay away from that. Some surgical contraindications. All of this is subject to the surgeon's idea. If the surgeon wants you to dry needle the very next day, that's his call. But 6 weeks with any tissue that's communicating with the area of surgery. And then if it is into the specific tissue itself, need to wait about 12 weeks on that. Some good precautions. Needle aversion is always relevant to what's going on. Somebody that has a strong aversion and you're really having to coax them, talk them into accepting this as a treatment, outcomes probably are not going to be that great. So the person really needs to have the buy-in to the potential benefits. One of the big things that we get concerned about is pneumothorax. Here we got to be very cautious about our needle placement in the thoracic cage. And again, additional precautions, our area of breast implant. If we're in the spine, we want to be aware of any surgical interventions, laminectomy, scoliosis, osteoporosis, any of those things that would adjust and rotate the level of the lamina, since frequently we use that as a backdrop. So in plantar fasciitis itself, I want to talk about 4 distinct areas that we treat, possible structures of problem. I'm gonna come back to the primary intrinsic muscles. When I treat plantar fasciitis, I always start more proximally in the extrinsic muscles. The tib posterior, flexor digitorum longus, flexor hallucis longus, and the peroneals, longus and brevis, not the tertius, it's there, but not for plantar fasciitis. So all of those structures originate on the posterior aspect of the calf and then dive down medially and laterally to finally attach into the plantar surface of the foot. And so my experience is I can deal with that plantar pain more often than not by dealing with the extrinsic muscles first without having to go into the plantar surface itself. So, and we'll demo a little bit of this in a minute, and those are the ones that I'm going to go to first. For the primary intrinsic muscles, a lot of things down there, but main things in order of probably relevance is the abductor hallucis, flexor digitorum brevis, flexor hallucis brevis, the Quadratus Plantae, and then the abductor digiti minimi if it's more on the lateral aspect. The deep intrinsic muscles, they can be needled. We want to stay away from midline to avoid the neurovascular bundle there. But here we've got the lumbricals, the plantar, and the dorsal interossei. Clinically, I don't find that they're all that often the culprit, the issue that's giving us our problems. But in the event that we can't get to the problem through the other structures, those are still things that can be dealt with. And then finally, the tendons and the ligaments, the long plantar ligament, plantar aponeurosis. Almost always, if it's towards the calcaneus, we're going to hit that medial process of the calcaneal tuberosity, a lot of attachment site right there. And then tendons of FDL, FHL, peroneus longus, and the TB. So from there, again, I'm going to start with the extrinsic muscles first. So I want to take just a moment and talk about our surface anatomy, our 3D anatomy. Let me jump from here. So we'll talk about first the plantar, the extrinsics. And here, let me get that. All right. So the main things here, and these end up being really nice, really simple needle applications. On the medial aspect, here we'll come in with the FDL and then flexor hallucis longus. Between the two sits the tib posterior, and so we'll take some nice approach there. As you can tell, these structures are all headed to the medial aspect. And again, the reason I treat these first is simply because any neuromuscular tension in these structures will be terminally felt on the plantar aspect of the foot. And so a lot kinder to hit those potential structures first than the others. Because on the lateral, we do still have Peroneus longus, Peroneus brevis that do come down onto the dorsum, or the plantar surface as well. Brevis is going to terminate there at the 5th digit, but as you can see, lots of structures just from the long tendons coming down here. So let's move to let my system catch up here. All right, into the primary intrinsic muscles. And whenever I don't get my results in the extrinsic, then I'm going to move here. Probably the most common culprit is the abductor hallucis. If it's along this first ray, abductor digiti minimi frequently comes into play. And if that's not our source of it, our source is directly, then we're looking at flexor digitorum brevis, or deeper, the Quadratus Plantae, which is just more proximal. You can see it right underneath there. And then there's always the flexor hallucis brevis that can be at play. So on the plantar surface, really, honestly, 1, 2, 3, 4, 5 muscles that we would look at there, I would always start abductor hallucis first on that surface. And so if we then move into the deep intrinsics, here we're talking about the lumbricals, the interossei. Again, they can play a role. Let me kill this. In pain and inflammation, probably not as much as most all of the other structures, but because they do control some of that deep movement. If other things aren't giving me the results I'm looking for, then I will come in and look at that. Again, we want to stay away from the midline because that's where the neurovascular bundle will sit. And so when we do needle here, we're just going to drop off the digit itself down into the muscle. And then finally here, we'll come back and look at one more on the tendons and ligaments, see if we can break those out just a little bit further. Again, so on the plantar surface, we've seen let me kill that. The tendon of Peroneus longus coming across from the lateral side all the way over to its attachment. So there's a lot of potential for a tendinopathy in that area. There is a tenosynovium further higher on the lateral malleolus, and that can be treated through dry needling as well. Tib posterior, as it's coming down as well in a really close proximity with flexor digitorum longus on the plantar surface to their origins. Probably the one that's more involved than anything, though, is flexor hallucis longus muscle. So we're evaluating a patient, and they've got that thick band that runs from near the calcaneus up to the big toe. It's just like a big bass guitar string. More often than not, we're talking that's the flexor hallucis longus tendon. And so, again, there's synovium, tenosynovium that could be compromised there. That brings back the point of one of the main things that I want to start with is into the proximal extrinsic muscles first. Get that relief there. Okay, so let's move out of there and let me come back. All right. So let's break this down a little bit further in a little bit more detail. And again, this will be available for you if you replay this video. So for abductor hallucis, basically we're going to split anterior posterior aspect of the malleolus, and then we're going to drop down. We're going to have the patient splay their toes. As we do, and we can palpate, then we're going to the needle insertion will be along the palpable muscle belly, in line with that malleolar midpoint, and we're going to direct the needle towards the medial process of the calcaneal tuberosity. So a smaller person requires a little bit different depth of needle than does a larger person. Needle length, here I'm indicating 2 to 3 centimeters. Most people, that 2 is probably not going to be quite enough. I've got a backdrop of either none or the medial process there of the calcaneal tuberosity. I can tell, I find more success if we go ahead and use the calcaneal tuberosity as a backdrop to get the full thickness, the full depth of that structure. With the angulation, I'm also going to possibly get some of Flexor digitorum brevis and Quadratus Plantae. And my general idea is I want to get as many structures with as few needles as possible. So this is the one where I try to layer several all at one time, and I just adjust my angle to make sure that I reach those. But in this case, we want to make sure that we're able to pull each individual muscle out distinctly. That's the location for Abductor Hallucis. For the Flexor digitorum brevis, very similar here. To identify it directly, we're going to drop all the way from the anterior aspect of that malleolus. It comes to the dorsum or the plantar surface of the foot, and then we're just going to needle through that area down to that medial process again. These are very uncomfortable needling locations. There's no getting around that. Again, one of the main reasons why I go to the proximal extrinsics first before coming to the dorsum or the plantar surface of the foot. For the Flexor Hallucis brevis, here our backdrop is going to be to the first metatarsal. So we're just going to palpate, locate that joint line, and then back up 2 to 3 finger breadths, and then needle down to that metatarsal as our backdrop. That lets us really isolate that. The Quadratus Plantae, again, we can take an oblique angle. Here, our backdrop will be onto the calcaneus. And again, I like to get that when I'm doing the great toe, the abductor there, to get that location. But here, needle placement can be in line, posterior aspect of the malleolus, and slightly cranial to the demarcation line. So that line right above where the skin changes from its more callous appearance to that smooth skin. Can be a little bit more tolerable above, superior to that line of demarcation. And then we're going to angle approximately 45 degrees medially toward the plantar aspect of the foot. And then we're going to use our palpating fingers as a backdrop to make sure that we don't exit the skin as we go through there. This location chosen for isolating this muscle simply because of the mildly less sensitivity above that line of demarcation. When we were looking at the previous screen of the Flexor digitorum brevis, obviously, if I'm going deep with my needle location here, I'm going to hit that as well. But again, here we're just looking to isolate that specific muscle. And then the abductor digiti minimi, again, we're going to splay fingers, splay the toes to palpate that muscle belly on the lateral aspect. We'll find the anterior surface of the fibula and then drop down. And then we're just going to needle to the lateral process of the calcaneal tuberosity. Again, you don't have to have a backdrop here. I tend to see that I see better results when I do have a lateral component of this plantar fascial pain to go ahead and take it to the backdrop. And so moving into the extrinsics, the tib posterior, here our backdrop is going to be into the fibula. We've got 2 possible, actually 3 ways that we can actually do this. Let's talk about the posterior approach first. Here we can just compress the lateral gastroc belly about 3 finger breadths down from the fibular head. And we're going to needle from posterior to anterior towards the fibula as a backdrop. Now, this is just purely patient dependent. If you want to take a lateral approach, in the 3D anatomy slide earlier, we saw that muscle really sits right in the in between tib and fib in that interosseous region. And so we can go lateral to medial or medial to lateral. Still, I would drop down about 3 finger breadths or 3 thumb breadths, and then go either lateral to medial or medial to lateral. I like to teach lateral to medial because there's less tissue on the other side to get to approximate into tib posterior. So tib posterior is a big one and an important one. For flexor digitorum longus, here again, about midway between the popliteal fossa and the malleoli, we're going to find a midpoint, and we're going to press the medial gastroc, and we're going to needle from PA lateral to medial with the lateral aspect of the tibia as a backdrop. Here we will needle through the soleus before reaching flexor digitorum longus, and are looking to hit the posterolateral aspect of the tibia to make sure that we get into this structure. For the flexor hallucis longus, here backdrop, we're going to drop down onto the fibula. Now it gets a little challenging to actually hit fibula. Getting a good sense of the location of the fibula in that bulk of that musculature back there. But if we do land on fibula, we know we've got a good placement through the bulk of FHL. Again, here we're going to compress the lateral gastroc at the mid-calf and needle from P to A. For peroneus longus, we're just going to go laterally, find the fibular head, drop down about 4 finger breadths, and go lateral to medial with the fibula as a backdrop to land in the bulk of peroneus longus. For peroneus brevis, we're just going to move further down. Has a lot less to do with plantar fasciitis. If there's a lateral complaint, then the peroneus brevis could be involved. Similar, peroneus tertius would be more on the dorsal surface, but you drop down just a little bit further to get into peroneus brevis. Included here, it's rarely involved with plantar fasciitis, however. Similar with peroneus tertius. And then also, we mentioned the ligaments, the long plantar ligament, the plantar aponeurosis, medial process of the calcaneal tuberosity, and then the tendons of the muscles themselves. Here, the long plantar ligament, basically here, we're just going to find the anterior aspect of the calcaneus, move forward, and we're just going to drop down to the calcaneus. Similar for the plantar aponeurosis, we talked about the line of that guitar string that runs near the calcaneus up to the toe, the great toe. You can catch the aponeurosis either at the calcaneus itself or at a midpoint along that flexor hallucis longus tendon, and that is going to be the location of the bulk of inflammation and discomfort there, and the plantar aponeurosis. So, I want to talk a little bit about the dry needling sequence for plantar fasciitis, and I've talked about this just a little bit. Dry needling of the plantar surface of the foot is painful. There's just no two ways about that. I've only ever had one person to get really excited about me putting needles in his feet. He works as an anesthesiologist, and somehow the wires in his brain aren't wired up right, but he let me put as many needles in his foot as I wanted to, and he kind of enjoyed it. So it's a friend of mine, so I can say that, but there's something not quite right to want people to stick needles in your foot. So with that, people do tend to be hesitant to start with treatment in the plantar surface of the foot, both because of the outcomes, but also because of patient compliance is why I tend to start in the proximal extensor musculature. That hesitance with dry needling in the plantar surface of the foot can lead to poor compliance and poor outcomes. And so, again, plantar pain is frequently the result of tension in these posterior calf muscles. Whether that plantar fasciitis is a cause of a flat foot that's caused a change in biomechanics at the ankle or at the knee, or maybe there's an issue on the contralateral side. Maybe they're limping because of a hip problem or a knee problem on the other side. Where we're going to feel that is in the extrinsic musculature. So evaluating for that plantar fascial pain, I palpate and identify any potential neuromuscular tension in those extrinsic muscles. That'll give you a great idea of where to start there. I typically will treat, if I'm going there, I'm probably going to hit all 4 locations. I can hit all of those with 4 separate needles, and I cover everything there. So if I do that 1 or 2 sessions, dry needling there, and then the appropriate stretching, strengthening, some manual therapy. You could also throw in some instrument assisted. You could throw some in any of your manual techniques can also accompany this and should. So if I do it a couple of times and I'm really not seeing a change on the plantar surface, then I will drop down into the primary intrinsic group, those 5 muscles on the plantar surface of the foot. If I'm still not seeing resolution after a time or 2 there, I'm going to drop in to my tendons and ligaments and see if I can isolate it to a specific isolated tendinopathy. And then if I'm still not seeing anything, then I'm going to fine tune finally in the deep intrinsics, the lumbricals and the interossei. 90-95% will be taken care of there in 1 and 2, the proximal extrinsic musculature and the primary intrinsic group. So I'll start Flexor Hallucis Longus. And we know we're going to have a fibular backdrop. I'm sorry, a tibial backdrop. Fibulous. A fibular backdrop. Man, it's Monday. It's Tuesday. So, and I'm going to palpate for that muscle. If I want to have her activate, I can have her activate those muscles. Experience tells me I know it's going to be right in that midpoint, and I can palpate that structure. And so I'm going to splay, drop in, and then down for the backdrop. For Flexor Hallucis Longus. For Flexor Digitorum Longus, I'm going to come to the medial aspect. And here I will look at trying to land on the lateral aspect of the tibia. Compress and drop to there. All right. For tib posterior, again, I can take a posterior approach, I can take a lateral or a medial approach. Muscle sits a little bit more on the lateral aspect. And so, truth be told, I may be getting a decent amount of the tib posterior with Flexor Hallucis Longus. But I want to make sure that I do get it. So I'm going to drop down 3 to 4 thumb breadths from fibular head. And I'm going to go right over the posterior aspect of that fibula, lateral to medial, so right there. Then lastly, if I want to get the lateral aspect in the pronaus longus, I can come, and likewise, I may be getting some pronaus longus with this needle for tib posterior, but to isolate it, again, find the fibula and then drop 3 to 4 finger breaths. And here I'm going to drop right onto the fibula as the backdrop. So these 4 needle locations, I get all of the extrinsic muscles. And I can do a lot with my plantar pain by treating that way. Normally at this point, I'll provide some electrical stimulation. I can do it with a point stem and do it for a 10, 15 second burst. Or if I so choose, we can hook each of these up to a mixed high and low frequency standalone unit that might run 10, 15, 20 minutes. 20 minutes is a long time. I usually run about 10. But that's a nice treatment approach there. Here, I'm going to go ahead and remove. And if you can solve a patient's plantar pain by dealing and kneeling in their calf as opposed to the plantar aspect of the foot, they will very much appreciate that. Okay. And so my subject today has to work this afternoon, so I'm not going to force her to be needled in the foot here. I'll just simply demonstrate with my indicator. So number 1 issue usually is going to be the abductor hallucis. So if you will go ahead and try to splay those feet. Okay, do that. We get a nice and relax. A nice strand of muscle belly right there. I'm going to split the malleoli. I'm going to come down. I'm going to drop. And from here, I'm going to needle. My trajectory is going to be for that tuberosity.
at the distal aspect of the calcaneus. And so I can come through here and get the bulk of that muscle. It is very long, and it could be needled anywhere along that course. If a person is more symptomatic, more distally, then we could come out here. For reproducibility, I like to catch here. So if we also wanted to catch, we talked about the Quadratus Plantae. If I want to catch that and isolate it, then I can drop down the line of demarcation, and then I can needle this direction. I'm going to use my fingers on the plantar surface to make sure that I don't come all the way through. So I can needle this direction to isolate that. Truth be told, if I'm going to needle through Flexor digitorum brevis, then I'm also going to catch Quadratus Plantae as well, right here. This is probably the least favorite needle on the foot, simply because of the tenderness associated. Unfortunately, around the calcaneus, this is the best needle for dealing with that inflammation in these intrinsic muscles. And then lastly, if I want to deal with the abductor digiti minimi, you could have the subject splay again, and it's going to pop out right here. I'm going to come across the anterior aspect of the malleolus, and then again, I'm going to needle here, and we're going to direct towards the lateral tubercle of the calcaneus on the plantar surface. So 5 super quick ways that we can deal with the intrinsics here. Again, the lumbricals and the interossei, rarely do I find that those need to be needled. If I'm going to, probably do that from the dorsal surface for ease of access and location of the digits themselves. So, all right. Demo is completed. Let's move back. I've got a few more things to do over on the computer. Thank you, subject, for participating.
So the really nice thing is I'm fantastic as a therapist, as a dry needler, but my audio visual is not always my strong point. So again, what I was saying was the folks that were able to get on, if you don't mind, indicate to me if you are have never dry needled before, if you have just taken an introductory course, what your experience is with dry needling, and that'll help me guide what I want these and what I need these webinars to look like. I try to gear it towards a little bit of everybody. So let me move back to sharing this. I want to talk a little bit about dosage and frequency. This is a method that I use and I find is very effective. For determining dosage and frequency, I typically divide everything into about 5 categories. And everything is determined on their activity level, chronicity of a condition, response to treatment, and probably the most important factor is their compliance to a well-developed home exercise program. We definitely can't fix a problem if our patient is not willing to do their part. Our goal in dry needling is to reduce inflammation, restore, so that we can then restore movement, strength, and functional activity. So that HEP, if they're not going to follow it, they're going to follow into a specific category. So first category is the athlete. 2 pieces here. One is an athlete with no comorbidities. It's a brand new issue. We're getting to it within the first 10 days of injury, and they have not had a significant deviation from strength or the performance level. Here, we're going to dry needle 1 to 3 sessions within the first 3 to 5 days, and that's really all we're going to have to do. Their prognosis is excellent. They should be able to resume normal training within 2 to 4 days. The next athlete is they have one or more comorbidities. This issue has been there a little bit longer. They've moved to a subacute stage, 14 plus days. Now they're starting to have some asymmetries in their strength and performance. There are some things that are changing. They're making some compensations. Here we're going to probably have to extend this a little bit, 3 to 6 sessions within the first 1 to 3 weeks. Prognosis, again, is excellent, but they're going to need 2 to 3 weeks of training to restore those asymmetries. Then they can resume their performance training. Next person is your weekend warrior, your average Joe. They're in decent physical shape. There was some incident that resulted in a strain or an overuse injury of a localized muscle or group of muscles. Here, the frequency of dry needling is going to be just 1 to 3 sessions within that first week. Prognosis is excellent. Yet here we get into the HEP. They're going to have to adapt an ongoing HEP to address the mechanical deficit that set them up for the injury in the first place. Something was already there, and they went out and did their crazy stuff, and then something really flared. So that HEP becomes much more important at this point. Then we have what I call the quick stick. This is your work colleague, family member, somebody who slept wrong, somebody who needs a quick fix. Dry needling frequency here, we're going to do it one time. And prognosis for these folks is simply fair. And the reason for that is they're going to have an underlying condition that will need compliance with an HEP to correct, but they're not going to be willing to accept that fact to be willing to do the work. And there's a decent chance this person becomes the procrastinator. And lots of us fit into this category. The procrastinator, they have 1 to 3 comorbidities. Something's underlying, something is creating the issue. And they've been dealing with it for several years, in some cases decades. They're unwilling to deal with the issue due to a variety of valid or invalid reasons. And now they've decided to do something about it. This is your 45-year-old who's decided, well, I'm old enough in life, it's time to get moving, it's time to do this and that. And so their frequency, this is going to take some work because it's going to take probably 8 to 12 sessions within that first 30 days. And here they can have a good prognosis, but it absolutely depends on compliance with the HEP that you set up for them. So good success still in knocking down that inflammation, that pain, give them the chance to restore normal movement and function and strength, but just depends on their willingness to do their work. And then finally is the hard case. Here there are multiple comorbidities. This is the person who has severe OA or DJD, the hip, the knee, whatever location, and honestly needs surgical intervention or an intervention, and it can't be done due to medical or personal issues. Either they can't get cleared for surgery due to a pulmonary or cardiac issue. I see it in a lot of cases where a person is a primary caregiver for a spouse or a dependent child, and they just can't be out for that. In this case, the dry needling can still be very helpful. Here, frequency of dry needling, first month, we'll do 8 to 12 sessions. The second month, we'll probably drop that down to 4 to 8 sessions. And the 30 days and beyond, we'll still do 2 to 4 sessions each month. Prognosis is fair. And honestly, this is a long-term maintenance case. This is one where it's that 1 out of 10 surgery is absolutely indicated and is probably needed to help them restore their function. The maintenance situation, insurance may be an issue, might be a cash pay situation. Here, treatment will be required until interventional clearance is obtained. It's non-pharm pain management. That's all this is. Dosage may have to be adjusted based on the patient's condition. Frequently, they tend to start feeling better. They get out, they do more. And unfortunately, there are just physical orthopedic limits that they're not going to be able to do more without further intervention. So treatment should improve functional outcomes, but withdrawing or discharging the service will result in a return to their prior condition. And then there's limited improvement with a progressive HEP. This is, again, I call it the hard case. If they were going to the pain management docs, where I kind of like to compete, we can manage that pain, but it's going to be a long-term similar if they're on pharmacological agents as well. So any questions that anybody has? I don't know. I may be able to get a chat situation in just a second. This webinar will be posted up to Haynes PT Institute. Actually, there will be a link there on my YouTube page where I record all of the webinars that we've done. And I'll send you an email with that link in the next 24 hours. I mentioned briefly at the beginning, I'm hoping by the end of this year to have all of the content of all 3 of the 2 3-day courses and the 1 2-day course into an online format that is obtainable through the website. I'm really proud of what I've put together so far. It's challenging to put everything into this digital format. It's not a substitute for the practical application. These courses are for those folks who just still hesitant to get out due to COVID, but still want to get that education piece. had a question earlier about certification. I will provide for everybody that takes the online courses, we'll provide a certificate of completion that will be readily available to you. For certification in the Haynes method, that still requires in-person dry needle training and verification, certification of the techniques. And so we do have some limited offerings for the rest of the year. I haven't set up 2021 schedule just yet. Give it another month or so, see how COVID shakes out, and then we'll start setting that up. But one of the reasons why I offered that that online piece, the first course, the introductory course, is already there, and should give it a shot. If you've done no dry needling, give that a shot. If you've already had an introductory course, it wouldn't hurt to look at it again. The cost is fairly cheap, and so it's a lot of good information there. So next webinar that I'm having on November 17th, we'll talk about thoracic outlet syndrome. And then on December 8th, we'll talk about Plantar Fasciitis. Okay, so I do have a question about needling acupoint KD3-7 to neuromodulate the nerve. So part of my training is I do have a little bit of training in the acupoints, but specifically I don't target specific acupoints in that regard. Acupuncturists are very well versed in that, and I'm going to say this is probably more to do with our licensure and our scope of practice here in Texas. We try not to step on their scope of practice in treating their acupoints. I can say neuromodulation. We do a good bit of neuromodulation dealing with incontinence in the pelvic floor. But to target specific acupoints, I don't include that in any of the training, simply because that's more, in the US, that's more of an acupuncturist approach. In Europe and the rest of the world, again, the physios, a lot of those folks are doing those things, but no, it's not part of what I do there. Okay, and I've got that one. Okay, and I've got another question. Person who's in Washington, and the Washington PT is not allowed to perform dry needling. Can I still get a certificate if I learn dry needling? Well, yes, you can. I will teach anybody who needs and wants to learn. The problem is my certificate doesn't outweigh your Practice Act in Washington. So East Coast, West Coast, curiously, the more progressive sides of the nation tend to be the more restrictive in physical therapists in dry needling. So I will absolutely teach, but you have to still comply with your State Practice Act in order to ensure whether it is permissible for you to apply that to a patient under your license as a physical therapist. Okay, so if there are any other questions, feel free. You can email me. Let's see, I should have my contact stuff here. You can email me, info@Haynes PT Institute, our Facebook page, Haynes PT Institute, or Instagram, or however, lots of ways to get to me. If you go to dryneedling.org, that's a lot easier to remember. That will direct right to our webpage where you can get the information. And if not, I will hopefully see each of you again next month when we talk about the thoracic outlet. Thanks a lot.